So central retinal vein occlusion, this is one of the second most common retinal vascular disease next to that of the diabetic retinopathy. The etiopathogenesis include whatever the condition that predispose to the hypercoagulable state, that is your virtuous triad. It includes altered blood flow, hypercoagulable state and hyperlipidemia. All those things will come, and your glaucoma, diabetes mellitus, dyslipidemia, hypertension, vasculitis and hypercoagulable state all will cause venous stasis, and it leads to likelihood to form thrombus formation, and that will cause a condition that is CRVO, that is important. And and you should know one more thing. This central retinal vein and the central retinal artery will come together as a together course, and if the atherosclerosis in the central retinal artery will cause a pressure implication over the central retinal vein too, and the pressure applied over the central retinal vein by the central retinal artery will cause the stasis of blood in the central retinal vein, and the stasis of blood in the central retinal vein will cause the features in the following. Broadly, the CRVO is classified into non-ischemic and the ischemic part. Okay, CRVO is classified together. It is broadly together classified into non-ischemic CRVO and ischemic CRVO. Most commonly non-ischemic is common, and it is hemorrhagic. It is also called as hemorrhagic CRVO. And what is the feature that is you should remember this unilateral mild to moderate sudden onset of loss of vision, whereas the hemorrhagic or hemorrhagic retinopathy or non-ischemic CRVO is somewhat better visual acuity is present, and your fundus will have less hemorrhage and cotton wool spot, whereas in ischemic there will be extensive hemorrhage and there will be cotton wool spot. And if you check with fundus fluorescence angiography, there will be good perfusion, whereas in ischemic there will be less perfusion. This is about your ischemic and non-ischemic CRVO. You should remember one more thing, that in non-ischemic CRVO there will be relative afferent pupillary defect will be absent, whereas in your ischemic there will be relative afferent pupillary defect will be marked. That you should remember. And regarding the fundus picture of both, you should remember there will be a splashed tomato appearance in the ischemic CRVO. Ischemic CRVO will have a splashed tomato appearance, whereas in your non-ischemic things you will have superficial flame shaped hemorrhage and mild venous congestion and toxicity. And we have talked about the pathogenesis, how it has came up, and we need to remember some clinical feature and some signs. What are the clinical features that you should remember with regarding this one is, as I said, CRVO will have the signs like mild retinal venous dilation and toxicity with small flame shaped hemorrhages, and mild macular edema is associated. And normally it will have features like your sudden loss of vision, and there will be no pain. Generally there will be painless loss of vision is associated here, and most of them are signs, and you need to see with that. And some of the complications are also present, that is neovascular glaucoma, vitreous hemorrhage and visual field defects will also be coming. The workup for the CRVO is, you should check up with the systemic diseases, since most of the causes of the CRVO is systemic diseases, so that you have to check up with BP, ESR, CBC, RBS and HDL level, ECG and echo. And in young patient you should check up with CRP, homocysteine level. CRP is for your vasculitis and homocysteine level is for also your vasculitis, and your thrombophilia level, which is for clotting factors, PT, APTT, antithrombin level, and your chest X-ray for your any cardiac abnormalities present or not. And for the regarding your investigations, another things are your general retinal function test retinal function test investigations like your FFA, OCT, OCTA, and your indomethacin green angiography. All those things are regular, and all those things are retinal function tests that you should do. And your treatment part, that is your that you should remember with conceptually, that is you could see here the blood flow impairment is present, intraluminal pressure increasing, so that is caused, that is here important. And why it is happening is that there is an increased interstitial oncotic pressure and macular edema that is promoted by increased VEGF and interleukin 6. If we give anti-VEGF drugs, this interstitial pressure will decrease and intraluminal pressure will decrease. That will cause less thrombosis of retinal vein, and there will be dysregulation in the intraocular immune response. If we give intravitreal corticosteroids like triamcinolone, it will decrease the inflammatory mediators, and it decreases the risk of vasculitis. So this is about your CRVO, and there is something called BRVO. BRVO is nothing but hemiretinal vein occlusion and quadriretinal vein occlusion, that are some small branches. The central retinal vein occlusion is your main branch that is occluding, whereas in the branch retinal vein occlusion there will be the features that will be confined to one quadrant. Hemiretinal vein occlusion, quadriretinal vein occlusion, and small branch occlusion are some features. This is about your CRVO and some of the important parts. It is discussed very lighter part. If you need discussion in the wider part, just follow us. Thank you.